Good evening, everybody. Our next speaker is Dr. Sandra Altman, who is a board-certified gynecologist with expertise in the management of perimenopausal and menopausal women, also known as the menopause maven. She will be talking a lot about issues that affect folks in this room who've had cancer treatment. And just a reminder that if you do develop a question for Dr. Altman, use the hot pink card. Thank you. Welcome, Dr. Altman.
Margaret, thank you very much, and thank all of you guys for coming. So I'm going to give your necks a break, okay? Because a lot of times when I talk, people will ask me to spell something or write it down. So you all have it written. And hopefully I remember it all, but I have my cheat sheet. So for most women going through a gynecologic cancer, it tends to involve removal of uterus tubes and ovaries. When the ovaries are removed, if you are not menopausal, you will be. And that's, you slam into menopause with a surgical removal, or you that have gotten there on your own, or you have developed cancer and you think, or somebody told you have to stop taking estrogen, so now you're symptomatic. So I'm going to focus on starting with how do you treat hot flashes. I'm going to talk about this thing that has this great name, they call it vulvovaginal atrophy, which will never get us on television because it's not cute like ED, and you can't call it VD or vaginal dryness because that means something else. So I've renamed it as DDD, dry down dare. And we're going to talk about how not to be dry down there. And then if I get time, a little bit about bones. So you can have there are millions of things that you will be advertised to you that will treat your hot flushes and flashes. One on the radio, Ambien. Has anybody heard this one? Ambien will fix everything, your weight gain, your sex life, your memory, your hot flashes, and there are studies that support it. So I looked up the studies. Those studies were done on, and I don't know who these are, actually. I was going to say who these people are, who these critters are, but they did studies on menopausal rats. I don't know how you know a rat's menopausal, but it was very effective. So most of these things that you see advertised are useless, and you might as well save your money. There's questions whether soy really works. The few studies I've seen, it doesn't make a difference for hot flushes and flashes. They did a study called Muffins for Menopause. I don't make these things up. And the bad news was it didn't make any difference whether you had a soy muffin or a regular muffin for your hot flashes. And the worst news was they all gained weight from eating muffins for breakfast. The only over-the-counter thing that has any data is black cohosh, which one of the brands is called Remifemin. And that, in some studies, work. They use it in Germany. Germany has a thing for botanicals, for plant stuff, that's like our FDA, and they have data for 6 months of use. I don't know what you do after the 6 months. My experience with the black cohosh is either it works really well for you or it doesn't work at all. Give it a month, and if it doesn't work, stop wasting your money. And then there's lifestyle things, layered, this is the stuff I just love. Layered clothing, at work, make sure that you have a white t-shirt because it goes under any suit, and a fresh bra and a Ziploc bag. This is true, this is what they talk. And a Ziploc bag and some little wipes and a little perfume so that when you get a drenching hot sweat in the middle of your workday and you need to freshen up to go to a meeting with your boss, you can slip into the ladies' room, take off your soggy wet clothes, put them in your Ziploc bag, put your fresh up on a spritz of perfume, and you're good to go. You can also get fans. There's something called abdominal breathing, which involves lying on the floor and doing deep abdominal breathing, which is a little hard to do in the middle of your workday. But these are some of the things. There just aren't a lot of really good, quote, alternatives. And if I had one, I'd be rich. Yeah, Sandy's got one of the fans. Fans. 100% effective, completely natural, no side effects. The gold standard for treating hot flushes and flashes is estrogen, okay? And there is no reason, if you have cervical cancer or ovarian cancer, that you cannot take estrogen. And the interesting thing is, as we've learned stuff over the last 12 years, estrogen alone has turned out to be terrific. The study you all heard about was estrogen progesterone. Got some problems. But what we know with estrogen alone, and if you've had cancer and you've had your uterus removed, that's all you're taking, is, when started age appropriately, within 10 years of menopause, has about a 32% decrease in heart disease, has a you ready for this? 24% decrease in the risk of breast cancer. Okay. I did not make that up, that is true. Estrogen alone lowered the risk of breast cancer. Early stage, later stage, death from breast cancer, and it lowers the risk of hip fractures, but the one that I think is most important is the 30% decrease in death rate. Death. Okay? Death. And when those women stopped taking their estrogen, all these differences went away. Two bad things went away. One was an increase in strokes, which is small in young women, and by the way, 50s and 60s is young, according to this study, and an increase in blood clots, which we avoid by not using oral estrogens. But you also, when you stopped, lost the decreased heart disease and decreased death. However, 5 years later, the decrease in breast cancer persisted. So estrogen got a bad rap that really belongs to progesterone. So for somebody who, unless it's endometrial cancer, okay, and that's what Dr. Lerner talked about, the estrogen-driven endometrial cancer, estrogen is a really excellent choice. If it's endometrial cancer, an early stage cancer, usually wait a year or two, make sure there's no recurrences, and it's probably okay. Then there's a whole list of other pharmacology, prescription medications, none of which are FDA approved or indicated for the treatment of menopausal symptoms, but we use them, okay, because there are studies that show that they work and they're effective. The one I like the best is something called Neurontin or gabapentin, that's the generic name. It works in the brain in the area that's sort of the hot flash control center. And there was a study where they compared very high doses of this to the old gold standard Premarin, and it was equal for relieving hot flashes and flashes. I never used that much because the problem is it makes you sleepy, and the women may not have had any hot flashes or flashes, but they were sound asleep all day, so that was a definite downside. It's a great trick if what you have are night sweats, and included in the handout is, because I have terrible handwriting, the thing that I give patients of how I kind of recommend starting with a low dose, giving it 3 nights, going up incrementally. Most people get real good relief with sleeping through the night and not being woken up with hot flashes and night sweats. The other one that we've used a lot over the years is Effexor. Venlafaxine is the generic name, in really low doses. It's not enough to be an antidepressant. It's the dose that they use for antidepressants for 1 week, and then you move up. Sometimes that's the daytime drug, and nighttime is the gabapentin, and that works. There's studies out on Lexapro, which is another antidepressant, that was effective. Most of these things work. It's about a 50% reduction in hot flushes and flashes. The other non-approved product is Megace, which is a progesterone. It's a very heavy-duty progesterone. It's one that the GYN oncologists and medical oncologists have used historically for treating endometrial cancer, and it's got great data, like an 80% reduction in hot flushes and flashes. Why is it not top of the list? Because 30% of women have weight gain, increased appetite, and water retention, and depression. And since you're already so cheerful about your diagnosis, that's probably not something we want to, add on top of things. But for the endometrial cancer patient, it actually is considered still a therapeutic treatment, and it may help your symptoms. The new one that's coming, it's a low-dose Paxil, and it's going to have a name. I don't even know what the name is. It's like Brethane or Breezy or something like that. And that was just FDA approved in a half-strength dose of what regular Paxil is, and Paxil is an antidepressant, was just approved by the FDA for the treatment of menopausal symptoms, which means that they had a study, because they're all done the same way. They had 380 some odd women who were having 7 to 8 moderate to severe hot flashes a day, and half of them got the drug and half didn't, and at the end of 2 months, there's about a 75% reduction in symptoms. So that's another one. It's not out yet. It's FDA approved, and I'm hoping that, and it's interesting because I usually see these things reported at meetings, and I haven't seen it yet, but the next menopause meeting is in a couple of weeks, excuse me. It's in 2 weeks. Another great medication for treating not just the hot flushes and flashes, but the general symptoms of menopause is actually testosterone, which is something I learned from one of Dr. Chen's predecessors, and I taught him to dial down the dose. Testosterone works sort of through a parallel receptor symptoms to estrogen. The difference is men have levels of 300 and women have levels of 15 to 70, and they don't make anything in our dose range. So that is something, it's the only place I really use compounding pharmacies to make something little enough for us. And included in the handout are all the different things, the pros and the cons. It helps libido, it helps energy, it's good for the bones, it stimulates the cells that build bone, it helps motivation, it actually helps vaginal dryness, muscle tone, cognitive function, excuse me. There are some downsides, all of which are reversible. If you stop it, no, you don't grow beards. 5 to 6% of women get facial hair, and it's just like little bit. That's why God invented electrolysis and waxing. Or you just dial down the dose, and it goes away. And I've had women tell me that their hair on their head got thicker, and some women say it got thinner. So I don't know which it does. The other thing that is really an easy fix, and no one should suffer from this, is the bladder and the vaginal problems. There is no reason that just because you've gone through a cancer, you have to give up an intimate sexual relationship. I mean, that's not something, unless you want to, that should be, you should be forced to give up. The over-the-counter products, there are lubricants. This is the latest thing from the North American Menopause Society. Their recommendation for painful sex, and I don't make these things up, their recommendation for painful sex is lubricants and frequent sex. Clearly a comment from somebody who never had painful sex, because that's not going to make you want to do it frequently. It just makes not such great tissue slippery. It doesn't help the elasticity. But lubricants do play a role, and they're helpful. We have a lot, vaginal estrogen got a bad rap for some very good reasons. It was a mess. And they gave you one applicator with a tube of stuff to last you for 2 months and didn't tell you how to clean it, except to tell you that it couldn't go in the dishwasher. So that lasted for 2 weeks. Also, we had no data on how much was absorbed, and you really can absorb a lot of estrogen through your system, into your system with these vaginal creams. So, I don't know, 6, 7, 8 years ago, along comes some better, newer products. The first one was this thing called an S-string, and it's like the rim only of the world's smallest diaphragm. It sits in the vagina. It has the equivalent of 2 tablets of estrogen, which is slowly released over 3 months. And that really turns the tissue back to what it used to be. I mean, it's really, for all of the things for any woman in the room, we've all been conned into, come on, buying those eye creams for $80, it's gonna like turn, us back to, turn back the hands of time and make all our wrinkles go away. These products really do turn back the hands of time. Unfortunately, vaginal estrogen does that by putting the wrinkles back, because you want good elasticity to the tissue. So the S-string is a great product for that. It doesn't bother people during sex. Women used to put diaphragms in order to have sexual relations, so that's not a problem. Next one that came along is a product called Vagifem. You got to wonder how they get these names. Or as one of my patients called it, Vagem. I may use Vagifem, but she uses Vagem, which you must get at Target. Vagifem are these blue sticks with these little tablets that have micrograms of estrogen in it. And I think I also, hopefully, included a picture of what it looks like. This product, so these newer products, they do studies, okay, and they measure estrogen levels before you use it and after you use it, and hopefully to convince people like Dr. Chen and her colleagues, you do not absorb any estrogen, okay? With the Vagifem, if you took a year's worth of these little white tablets and made the world's largest tablet and tried to swallow it, which wouldn't be good because it sticks, you would get the equivalent of 1 tablet of estrogen in a year. like the accidental ingestion of 1 tablet of estrogen, which really doesn't do anything. And the estrogen levels that women have remain in the basically by a regular lab undetectable level. It's our lab at John Muir can measure up to a level of 12. And if you look at the very first day, 2 weeks later, 2 months later, those levels are below 12. Before I tell you about the newest product, because I put a handout in there for you, the other thing that people don't appreciate is the bladder symptoms. And one of my other jobs is I'm the medical director for John Muir Women's Center for Continence and Pelvic Health, the Potty Center. And the bladder, like the vagina, is an estrogen-dependent tissue. And when you lose the estrogen, the bladder loses elasticity. What happens if you can't stretch, you are full at a smaller volume and you have to go more often. So instead of waking up once during the night, you're up 5 times during the night. Okay? To be woken up 5 times during the night, and you have to get up and you have to go to the bathroom and then you have to get back to bed, I call it the Guantanamo situation. When they do that at Guantanamo Bay, they're doing that purposely to disrupt people psychologically and cognitively. Okay, so it's not a healthy thing to have your sleep disrupted like that. And the receptors on the outside of the bladder, the one that you see all those ads about gotta go right now, also respond to estrogen, those receptors, and they get twitchier. So you have urgency, you have frequency, you can't hold it, you're getting up more. And one of the more amazing things I've learned from the Continence Center is when this will work. We've started women on their 70s and in their 80s who come in with leaking, and a large part of what gets them better is vaginal estrogen and physical therapy. And women will say, now that I don't wake up 5 times a night and I only get up once or twice, I have less senior moments. Well, she wasn't having senior moments. She was having sleep deprivation. Somebody had shipped her off to Guantanamo like she was a poor little terrorist and was disrupting her sleep. So that's another problem that is really fixable. And these localized drugs have much less side effects than the overactive bladder, the Vesicare, and all of those. Although one of those drugs, there's a patch version that's now over the counter. I saw yesterday on TV. The newest medication that we have is one called Osphena. And it's in your bag. Sandy's motioning to me. It's in, the handout is in the bag. This is really new. I think it's been out 2 or 3 months now. This medication, it's called a selective estrogen receptor modulator. So it's in the same family as tamoxifen that's used for breast cancer, raloxifene that's used for osteoporosis and breast cancer prevention. This one, I don't know how they got it to do this, but this one goes to the estrogen receptors in the bladder and the vagina and turns them up. So it's an oral medication that's taken daily, but gives you the same effect as the topical vaginal estrogen, but it's not really estrogen. This is something that would be really nice for the endometrial cancer patient because they have looked at it in terms of does it stimulate the uterine lining? And the answer is no. Because the different kinds of studies that are done to get things approved, when you're looking at vaginal products and your endpoint is vaginal dryness and the health of the vaginal tissue, the pH, the bacteria, how mature and healthy those cells are, that's a 1-year study. If you're going to look at something like bones, which raloxifene or Avista does, that's about a 3-year study. If you're going to look at the breast stuff, they got some data on Avista out at 3 years, tamoxifen, they have 5-year data. So we haven't seen this drug out that long. So I don't know what it will or will not do for that. My prayer was that we'd have the breast data. And then I can make everybody happy, the oncologists, my patients, because I had the perfect drug that lets you have sex and cuts down your risk of breast cancer. But we don't know that. I'm going to cross my fingers and hope, but we don't know that. The other thing that I want to encourage people, and you'll hear a little bit more about this, is the role of physical therapy, particularly if what you're having, with some of the more dramatic surgeries, which actually it's the only gynecologic surgeries we do, which actually end up shortening the vagina a little bit, and really pulling and contracting some of that tissue. And then if you add radiation to that, where the things really do get contracted. Working with physical therapy is important, and you'll hear a little bit more from Allison. And at the Continence Center, we have 2 gals who do pelvic floor physical therapy, and it involves hands-on work for muscle relaxation, for muscle strengthening, and oftentimes by the time we see people over there, they're 5, 6, 7 years out, particularly after radiation, and this tissue is really kind of rock hard. And now we're really behind trying to get it so that people are comfortable with sexual relationships, just comfortable in general with pelvic pain, trying to get the bladder to function better. So it's not a bad idea if you're going through these surgeries to make that connection early on. And I put a little blurb, and at the bottom is our information about the Continence Center. My last piece is in terms of the bones. One is any woman over 60 should have a bone density, okay? Actually, they officially say 60 if you have risk factors, 65 for all of us. Risk factors being after menopause, so most people over 60 women qualify for that. We need adequate calcium. Adequate calcium is 1,000 milligrams a day, okay? And that includes what you get in your diet, which we sort of forgot, and we gave women so much, calcium, they're all constipated and unhappy. So figure you get about 500 in your diet, you need another 500. Most of the multivites for women have 500 milligrams of calcium in it, and that's kind of all you need. If constipation really is a problem, you get a calcium magnesium supplement, like milk of magnesia, right, which goes the other direction. What we really need is vitamin D. And vitamin D is probably one of the few things you will not get in your diet unless you consume a lot of herring, sardines, and mackerel, and unagi, which most of us, unagi.
I'm sorry, I didn't understand.
Herring, sardines, and Japanese eel. Most of us don't. Or you spend a lot of time outside without sunblock, okay? In which case now you have skin cancer, so we don't do that either. So vitamin D we really do need to take as a supplement, and probably about 2,000 international units a day, okay? We really under-recommended, we under-recommended that for a long time. It plays a definite role for our bones, for how we absorb calcium, and we're looking now at studies about its impact on cancer, cancer prevention, and cancer recurrence. We do know that having low vitamin D is associated with higher risks of colon cancer, breast cancer, prostate cancer, and heart attacks. The question is, does changing that rolling forward make a difference? Okay? And my feeling for my patients is, look, we know we need it for our bones anyways. So I don't want my patients in the placebo part of that study. I want us to be taking our vitamin D. If you do have osteoporosis, estrogen is an excellent drug for that. We do know that estrogen decreases the risk of hip fractures. Hip fractures are a really bad thing. It's not just a bad thing if you have it. It's a bad thing for your family members, because my folks were visiting me when my mother had her hip fracture. And I really got to see how difficult it is for somebody to recuperate from that and how much caregiving is required. Avista or raloxifene is a good medication. Also has the advantage of a 70% decrease in the risk of breast cancer. Then there's the whole family of osteoporosis medications, Fosamax, Actonel, Beniva, and I'm using brand names because I can't pronounce half the generics anyways. Reclass, which is an IV version. Most of these medications are very, very safe. You see stuff on television or ads, have you taken this drug and had this horrible thing happen? The osteonecrosis of the jaw, the funny fractures, and the long bone of the thigh are very, very rare. And we now have a way of calculating for an individual woman, what's the chance that you're going to have a hip fracture in the next 5 years or 10 years? And if that risk is high enough, then it's worth taking a medication that has a very small risk of one of these other problems, but you kind of do a risk-benefit balance. There's a new medication out called Prolia, which is just amazing because the impact on the bone density in the spine and the hip just goes like that. And unlike the other drugs, it never tapers off, it just keeps going. The Prolia is a twice-a-year shot. Reclass is a once-a-year IV infusion. and they have some interesting anti-cancer properties. Dr. Chen and her colleagues will use this. It helps prevent bone metastases or helps to heal bone metastases. So some of these things have odd and unusual side effects, if you will, that are really benefits. And that was my quick run through.